This patient has a history of ulcerative colitis. And so the concern is with a history of autoimmune disease, is an immunotherapy option really the preferred approach? We know, immunotherapy works by trying to rev up the immune system, and a common toxicity is immune-related adverse events where you get autoimmune toxicities. And if you have an underlying autoimmune disease, there's certainly a concern. And these patients were excluded from the clinical trials that led to their approval. There have been retrospective data led by Dr. Harshman at Dana-Farber, showing that in patients with a history of autoimmune diseases, looking at those with urothelial carcinoma or renal cell carcinoma, immunotherapy can be given to these patients safely with, expected immune-related adverse events. But obviously, that's always a concern when looking at these patients. So in someone who has a history of active ulcerative colitis, that they're on ongoing therapy, if they're needing steroids or they're needing sort of disease-modifying agents, I think, you have to be worried about the toxicity of immunotherapy, especially when we have other options in the front line. So in someone like this, I think if you're going to elect treatment, a drug like cabozantinib would certainly be very appropriate when there's that concern for immunotherapy. With the thought being, you start with cabozantinib. If you don't get the response, then you can certainly entertain doing immunotherapy in the second line, potentially in monotherapy, given that's where nivolumab is approved. I think one of the questions before you decide treatment is, can you offer surveillance? Does this patient actually need therapy? So, this is something, especially with good risk disease, where surveillance is certainly an option. And it's actually been studied in a prospective study by Dr. Arini and colleagues that's published that show that, patients with renal cell carcinoma, surveillance is a reasonable option. And in their study, the median time off therapy was just around 15 months. Looking at that, specifically the number of metastases, IMDC risk stratification, were sort of helpful in determining who would be the best for surveillance. So I think surveillance is certainly a reasonable option in someone who has good risk disease. And so it's something to always entertain. In this patient, you could argue that potentially his mild anemia could be from his ulcerative colitis, and with his relatively asymptomatic, you could certainly offer surveillance in that situation. But I think with the number of metastases he has, bone metastases, I think certainly therapy is very reasonable. In this situation, I think I would think about systemic therapy. And to further support the role of cabozantinib, I think one of the things that we know in renal cell carcinoma is challenging is the presence of bone metastases. So in those patients with bone metastases tend to respond poor to systemic therapy. And what's been seen in cabozantinib, both in the Cabozan as well as the Meteor trial, is it does have activity in bone metastases. So in those patients that have bone metastases, which may be historically resistant to some of our targeted therapies, cabozantinib certainly plays a role in those patients.